Hello, everyone, and welcome. This is Nicholas Giardina with MCOL, and I'll be your moderator. We're so very glad you can join us. Our webinar today is the NJ Medicaid ACO Demonstration 2018 update. Our speaker is Dr. DeLia, Director of Health Economics and Health Systems Research with MedStar Health Research Institute. Before we get started, we have a couple of housekeeping items. Our speaker will be taking your questions via the chat feature. While all questions will be addressed at the end of the presentation, you're more than welcome to send your questions now and at any time throughout the webinar. To chat, please click the blue talk bubble on the bottom left-hand corner of your screen. If you would like to receive a copy of today's presentation, you can download it from http://healthwebsummit.com/ACO041118.pdf. Lastly, if you require any assistance, please contact the Healthcare Web Summit office at 209-577-4888. Derek, we are ready for you to begin.
Thank you, Nick, and good afternoon or maybe good morning for some of you. Thank you for joining the webinar today. And before I get started, I just want to acknowledge a handful of organizations who have provided some financial support along the way to support the evaluation activities and other activities that are related to the New Jersey Medicaid ACO demonstration. So first, I'd just like to outline some of the really broad goals of the demonstration, what it's really all about. So this is a 3-year kind of an experiment developed by the state of New Jersey to try and explore issues around accountable care and shared savings within the New Jersey Medicaid program. And it's a demonstration, so we're hoping to learn from the experience and then figure out what should come next for New Jersey Medicaid. The idea is to really start slow, start with really low provider risk, thinking about one-sided kinds of shared savings models, not putting providers at financial risk just yet, certainly not during the demonstration, but ultimately maybe over time with the learnings from the demonstration, maybe move to greater risk-bearing at a later date. So the way the demonstration is designed is the state is really trying to achieve this balance between being flexible. They didn't want to tell the ACOs exactly what to do. We want some flexibility to allow for innovation and what the ACOs think they should be focusing on and how they should do it. But the state is also exercising its oversight responsibilities to determine what the rules are, what you have to do to call yourself an ACO and things like that. And the state also wanted to limit its own financial exposure. The state was not interested in creating a new program or a new spending item in the state budget. So they wanted to limit the financial aspects of it from the perspective of state liability. Okay, so here are some of the key details of the demonstration. So it runs for 3 years, began on July 1st, 2015, and it's a geographic-based model. So if you want to be an ACO during the application process, you would have to decide what is the geographic region that you're targeting. And typically, this would be a collection of zip codes in your local area. And the one rule is that you have to have at least 5,000 Medicaid enrollees living in your designated area. And New Jersey's densely populated state, so that's not really a difficult requirement for most places that are interested in doing this. There are different levels of accountability for ACOs, and again, there's some flexibility here. ACOs would choose from a menu of total cost of care metrics and quality and outcome metrics for all their Medicaid enrollees in their designated geography. This is designed to be kind of a multi-sector model. So to be an ACO, you need to have a board of directors where there's wide representation, not just healthcare providers, but also social service representation, and also representatives from patient groups, advocacy groups, community groups, places like that. So this does have a shared savings component built into it. This is something that is a requirement for Medicaid fee-for-service populations that are in the geographic areas. This was designed to be voluntary for managed care organizations, and it turns out that's a really important feature because the state of New Jersey, it's more than 90% managed care in terms of Medicaid enrollment. So interactions with the managed care organizations turns out to be a really important part of this, and we'll talk about that a little bit in a few minutes. So the state set up a pretty detailed certification process to become a Medicaid ACO. These are just some of the highlights, but they kind of show the tension that happened at the state level between wanting to be flexible, letting the ACOs figure out how they do what they want to do, but also exercising state oversight over some of the details. So to become an ACO, once you designate your proposed geography, within that geography, you need to have all hospitals in the area as part of your ACO, so you're encouraging collaboration rather than competition between the local hospitals. You need at least 4 behavioral healthcare providers, and within your geographic area, you need to have at least 75% of the Medicaid participating primary care providers agree to be part of the ACO. There's also shared savings, or what we call gain sharing. And here, this is where the ACOs have some flexibility as to how they want to set up various parameters. The ACOs can propose their own gain sharing plans. They need to be tied to the state-endorsed quality metrics that I mentioned earlier. But they can develop it on their own, and then subject to state approval, can move forward with it. On the managed care side, it's voluntary, but the ACOs are set up so that they can engage in negotiations with managed care plans, and then it's between the managed care organization and the ACO to determine the details of how all that's going to work. So initially, 7 communities applied to become certified as Medicaid ACOs. Ultimately, only 3 were approved. These are ACOs in Camden, Trenton, and Newark. And the places that were denied certification, there were various reasons why they couldn't meet the requirements. One of the big ones was this gathering enough primary care providers. It turned out to be kind of difficult for people to find and document and agree on who exactly are the primary care providers in the region, and how do we get to 75%. That wound up being a big sticking point for the applicants that ultimately were not certified. Okay, so I mentioned 3 places were certified to be ACOs. So this just gives you a look at how many Medicaid beneficiaries live in these regions. And when I say Medicaid, I'm referring to Medicaid CHIP together. And here are the numbers I have displayed here. I would say they're probably an overcount just because in the data we had to look at, we just measured how many people in the designated zip codes had at least 1 day of Medicaid enrollment in calendar year 2015. And of course, some people are in and out very quickly. There's churning on and off the program. So in terms of people who are really continuously enrolled, the people where you could really interact on a regular basis and do care management, those numbers would be a little bit smaller than this. But this gives you a rough idea of the size of populations that we're looking at. And it might look a little unusual how the numbers in Newark are kind of small, given that Newark is the largest city in New Jersey. But the Newark ACO is not the entire city of Newark. The Newark ACO decided to focus on part of the city just to make it a little more focused, a little more manageable in the beginning, so that the Newark numbers are not the entire city of Newark. So the three ACOs really work within a broader community that I would say is part of the total demonstration project overall. Okay, so at the center of it all, you do have these three certified ACOs, and the way this is designed to work is ideally the ACOs would negotiate contracts with managed care organizations. I listed some other organizations that are providing different kinds of support in different ways. So I guess on the top and to the right, kind of to the northeast, you have some funding support. So certainly the Nicholson Foundation, which is a local foundation in New Jersey, they've provided various levels of support to the different ACOs at various stages, philanthropic funding. I mentioned they're supporting some of the evaluation work that is really centered at the Rutgers Center for State Health Policy in New Jersey. Then there's some federal funding that has supported evaluation work and technical assistance work. A lot of that has to do with helping the ACOs get set up with data feeds and creating variables and understanding how to use the data that the state provides to them. And here I'm referring to Medicaid claims and managed care encounter data that's relevant to the people who live in the ACO's designated areas. And having that data come from the state, it turns out to be really important, because just because you live in a certain area, that doesn't mean you're only going to providers in that area. And with this data, you can get a full picture of where patients are going at what times, which is really critical for any kind of care management kinds of activities. I listed the state of New Jersey, DMAS, which is the Division of Medical Assistance and Health Services. That's who runs the Medicaid program. So they're certainly in charge of the oversight, providing the data, working through technical issues on the data, and there's some funding involved from the state, which I'll talk about in a minute. Oh, and I also should mention the New Jersey Healthcare Quality Institute. That's an organization in New Jersey. It represents providers, and it's kind of become sort of a trade organization for the ACOs in New Jersey and other similar groups that are interested in doing similar kinds of work in New Jersey Medicaid. And they do a lot of convening and organizing and providing some support for the ACOs as well. So here's the timeline of some of the key activities. The enabling legislation for the demo is, it goes back to August 2011. Took a while to put together all the regulations and the final rules. There were proposed rules and then a public comment period, and that took a little while to get the final rules issued, which was done May 2014. Then communities could apply to become ACOs, and so that brings us to July of 2015, when the demonstration officially started, and it started with the three certified ACOs. So along the way, other things happened. A really important component of this is the access to the Medicaid claims and encounter data. ACOs got their first round of information from this in February of 2016. Okay, so that's well into the first year of the demonstration, which ended in June of 2016. July 2016, we began the second year of the demonstration, and the second year added some state funding for the ACOs. So originally, this is not what the state had in mind, but it became apparent that the ACOs were really struggling to do a lot of their early activities, and it was felt with some state support they could accelerate and move forward a little more quickly and do the things they need to do to get started and up and running. So kind of at the last minute in the state budget, the state appropriated $1 million for each ACO, which is, serving as sort of startup funds. And then that took us to the end of the second demonstration year. Third year began in July 2017. And then again, late in the budget appropriation process, the state decided that it would be useful and appropriate to provide one more round of funding to the ACOs, $1 million each. And here you can see some of the tension that, originally the state wanted to limit its financial liability, but then once this thing got rolling, it became apparent that, the ACOs needed some startup support, and so that's how it evolved. Eventually, some funding was provided to supplement whatever philanthropic funding the ACOs could raise on their own. And then I should mention that the demonstration, the official demonstration ends in June of this year, which is just a few months from now, and there's certainly still a lot of work for the ACOs to do, which we'll talk about in a minute. They're hard at work doing all kinds of activities, and then subsequent evaluation work is underway and will continue after the demonstration ends, so we can look back and see exactly what we learned from all of it. Okay, so we have done a little bit of evaluation work around different elements of the evaluation, and here, just to keep it high level, I'm going to present just a handful of high-level themes that we're starting to learn from some recent qualitative analysis where we at the Rutgers Center for State Health Policy had been doing site visits with the various ACOs, doing semi-structured interviews to really learn in some detail what's going on, what's happening on the ground level. So these are some preliminary themes, kind of broad for now, but the first one we're finding is that access to this claims and encounter data that I keep mentioning is really emerging as the most important resource that the state is making available to the ACOs. Certainly money is always important, but it's really the data that is enabling the ACOs to organize themselves and do what they want to do. There's a lot of richness in this data, providing information that the ACOs would not have otherwise. Theme number two is that the ACOs are really serving as the conveners and the connectors for the community to really build upon the things that providers in the area would like to do anyway, but really enhance what they're doing and make it bigger, make it better, and sometimes initiate new healthcare delivery innovations in their local areas. So the ACOs have really become the hubs of all kinds of activity that's going on in terms of improving care for Medicaid and other underserved populations more broadly. And then theme number three is that the ACOs are using their startup funds from both state and private sources to leverage other kinds of grant revenue to bring more financial stability to what they're doing. And this appears to be the main source of funding for the foreseeable future. We'll talk about shared savings and other things in a minute, but for now at least, it looks like the grant funding is still really a pillar of any financial sustainability that the ACOs are going to have in the near term. Okay, so now I just wanted to summarize a little bit about what's happening with each ACO group in particular. So the first one is in Camden, and the official name is the Camden Coalition of Healthcare Providers, and I suspect a lot of people in the webinar know who the Camden Coalition is. They've been doing this kind of work for a long time now, even before the Medicaid ACO demonstration was developed. So this is really a very experienced provider coalition. And for them, the demonstration is really just, it's allowing them to build upon and expand the work that they had been doing previously as a coalition. So in terms of funding, Camden's been doing this for a while and is supported by a variety of grant funds, so that the state funding was not a large portion of their operating budget, about 10% overall, but it allows them to expand and explore other avenues that they might not have been able to do otherwise without the state funding. So as the demonstration was being developed, Camden was already in conversation with some of the managed care plans in New Jersey, in New Jersey Medicaid. And so under the demonstration, they've been able to continue that and expand a little. So they have a history of working with United Healthcare on a shared savings arrangement. Just before the official demo started, they did some contracting with Horizon, Blue Cross Blue Shield. And so they've been moving forward with a lot of that. I think the folks at Camden would say they're achieving some successes on the ground, and there's certainly a lot of learning about how to coordinate with managed care plans, how to do a better job for patients. At this time, there's no evidence of really population-wide shared savings, across the city of Camden. But there's still a lot of learning going on and ongoing negotiation with the plans about how do you do this, how do you do this well, how do you measure savings, and what are the appropriate quality metrics. So certainly, even though we can't give a dollar number and say, hey, they saved X dollars of money, there's still quite a lot of activity and learning that's going on. And the contracting with the managed care plans is really being used as a vehicle to explore different kinds of initiatives, how you would target various subpopulations that would be of interest to the health plan as well as the ACO. Beyond shared savings, Camden is also looking at negotiating other kinds of contracts, more like service arrangements where you'll have some kind of per member per month, kind of a care management fee, and make it more of a narrowly focused kind of a thing, not being at risk for any savings or expenses for that matter, but having just a clear contract where you're going to provide care management services, things on the ground, connecting with communities that managed care organizations might not be able to do so well. As I mentioned, Camden has a lot of things going on. I'll just highlight a couple things that have been moving forward under the demonstration. They've developed this initiative called the 7-Day Pledge, where they work with primary care providers in the area, and they make a pledge where they say if a patient's been in the hospital after discharge within 7 days, they're going to arrange a follow-up visit and make sure the patient has what they need to hopefully stay out of the hospital next time. And the ACO provides some financial incentives around that, and by providing financial incentives, the ACO can arrange meetings with each of the providers and talk about what their care coordination is going to look like, how have they done recently, and how they can do better. And they're currently continuing this initiative, thinking about refining the focus in terms of patient inclusion, for whom would this initiative really work best, and how do you implement specifically the financial incentives. Also, Camden is looking beyond the health system activities and looking at some of the multi-sector kinds of activities that influence health. So they're developing interventions where they're working with people who are homeless and really trying to integrate data, looking at housing service information integrated with their health information exchange, which they've had up and running for a while now. So you can kind of bridge the gap between the medical side and the social services side. Also moving into jail data to try and work with people who've been in and out of jail, who are certainly at very high risk for all kinds of health problems and healthcare utilization. Also working with the schools to deal with some pediatric issues and the overlap there. next we have the Trenton Health Team. This is another group that really had some significant coalition activity occurring before the demonstration, but under the demonstration they've been able to really solidify and expand a lot of the work that they've been doing. One of the big things that the Trenton Health Team has done under the demonstration is they developed this data platform working with Care Evolution, which is a health data company. Here they're able to put together a community-wide health information exchange where they have data coming from their providers in the coalition, but also enhancing that with the broader claims data that's being provided by the state. And this has become a vehicle that really drives probably all the activity now at the Trenton ACO. It drives their planning. They can do rapid evaluation of what they're doing and how they're doing it and make adjustments along the way. And it's also a good tool for developing really detailed grant applications. Because certainly if you apply for a grant, you can't just ask for money. You need to demonstrate what the need is, where the gaps are, and what precisely the grant would be filling in. And having the data to do that is a really important tool for attracting some of the funds to support the work that they want to do. Under the demonstration, the Trenton Health Team has become the real kind of the go-to organization for providers in the community. So they serve as a convener. They facilitate really new initiatives that are going on in the community. And as I mentioned, if people in the community want to, go for some grant funding to do any kind of public health kind of initiative, the Trenton Health Team has the data, has the coalition, and they can convene people to move forward with that. And Trenton's been pretty successful on that dimension. By bringing in grant money, it gives them a little more financial stability, so they can continue to do their work and plan ahead a little bit. So Trenton has not developed really shared savings arrangements with managed care organizations. They've been focusing more on the service contract kind of a strategy where there's a defined set of services that the coalition can provide in support of what the managed care organizations are trying to do, providing that real ground level interaction with patients and coordinating with other groups on the ground. And rather than depending on savings to emerge, it's more of a straight contract where managed care plans would pay a fee to get the services that they're providing. Trenton's also linking with other activities in the Trenton region that are just going on. For example, hospitals have their Schedule H obligations. Under the IRS code, hospitals that are not-for-profit have to demonstrate that they really are providing community benefits in their area. So by coordinating with the Trenton Health Team, they can do some of that and do it in an effective way and in a way that also satisfies their legal obligations to do so. Trenton works closely with city government on any public health kinds of initiatives. You have the coalition there, so they can help to implement and help influence whatever the city government would like to do in terms of improving public health in the city. Just a few other quick points. The Trenton Health Team is developing some home visit strategies, working with community health workers to help people manage their conditions when they're not in a clinical setting. So that's an important addition. And one thing that's standing out for Trenton is that there are lots of issues with diabetes in the region, and so Trenton is really working on diabetes interventions, everything from care coordination to sort of health coaching and mentoring to help people, better manage their own diabetes care. So next we have Healthy Greater New York. So this is the Newark ACO. And so in Newark, they really didn't have as well developed a coalition before the demonstration as the other sites. So Newark has had to really build a lot of it from the ground up. And Newark is really it's really a complicated area. The market in Newark has a really big dominant hospital system in the region. There's one public hospital. The hospital sector overall is kind of in flux. There's always talk about whether hospitals are going to close. Some have closed over the years. Some might merge. So this is just by way of saying that the Newark Coalition really walked into a situation that I think is pretty unstable, kind of hard to develop a coalition and a care management focus because there's just so many other complicated things going on in Newark. But they're still moving forward. They're developing their coalition partners, thinking about where to focus some of their care management activities. And along the way, because Newark is so complicated, they're really starting to rethink their geographic focus. Originally the thinking was that Newark is a big place, so let's start small, let's be really narrow and focused. But it turns out people and providers kind of cross the boundaries of the original geographic area that they had in mind initially. So I think Newark is really reevaluating whether that's the right geography for them. Maybe they should expand it a little more in order to bring in the right partners and target the right patient groups. So under the demonstration, you're locked into a geography, but in terms of what you really want to do, Newark is thinking more broadly than the original demonstration geography. So Newark has been hard at work at developing their own care evolution platform, similar to what Trenton has been doing. And I should mention that the ACOs have been really collaborative in terms of working through the New Jersey Healthcare Quality Institute, sharing information, coaching each other. And so certainly, the Newark ACO is learning from the Trenton experience and the Camden experience, but they're still developing the care evolution platform. And they really view that as a key to doing all the other activities that they would like to do. Without the data platform, it's hard to bring people together around anything specific. If you're applying for funding, it's always much better to have some real information in hand to describe what exactly the gaps are, what you're going to do, and then how you're going to measure results if you get the support. So the care evolution work is still ongoing, and once that is in a more advanced stage, hopefully Newark will be able to move forward with more detailed kinds of activities. So for Newark, things are a little uncertain with the marketplace and with the funding. So because of that, the Newark ACO has been moving more cautiously. Okay, so instead of hiring a bunch of full-time people, putting them on staff, not knowing if the funding is sustainable, they're doing some creative things like working with the local hospitals. Hospitals have their own care coordinators, so Newark is buying some time from them, not making a full-time commitment, but working with people part-time to help start some of their patient engagement and care coordination activities. And Newark is also really focused on aligning the work that they're doing with other work that's going on in the area, so that the Newark ACO can play a supporting role. For example, the hospitals, they have to meet various quality metrics for the New Jersey DSRIP program, and to the extent that the Healthy Greater New York can help hospitals with their DSRIP requirements, that shows Healthy New York can be effective, and then you can build a coalition from there. Okay, so here I'll step back again and just think a little more broadly. This is how the demonstration has evolved thus far. Okay, so if you think about the original vision when the legislation was written was really this kind of broad population health concept, and everybody, when you say ACO, they think this is great. We're going to have real cost containment. We're going to do shared savings and all these big things. But I think it's kind of similar to the Medicare ACO experience. it's hard to do all that within 2 or 3 years. And so looking at the later development of the ACOs, they're doing some other things. It's not quite, broad citywide savings generation, but it's really developing the coalitions, building the infrastructure in terms of data, in terms of getting the right partners in place. And each of the ACOs have really been focusing on targeted subpopulations, okay, whether it's, people who have housing needs or diabetes groups. You really can't look at everyone right away. And so trying to look at, citywide quality metrics, you probably won't see a lot of movement right away. But if you look in more detail at the targeted subgroups that ACOs are working with, that's where you probably see some more movement. Okay, so for now it's not huge. It's community-specific activity. It's infrastructure building. ACOs also really doing a lot of convening and facilitating, and in the health sector, everybody's doing a million things all at once. Other initiatives are going on, so the ACOs are trying to plug into that and enhance and help other providers do a better job at what they wanted to do anyway. Keep coming back and forth with the managed care organization participation. This is really a big deal for the demonstration, as a demonstration per se. Engagement with managed care organizations has been pretty limited, and that really limits a lot of what the ACOs can accomplish, in the 3-year demonstration. And this has been an ongoing theme. There's this ongoing dialogue between the ACOs and the managed care organizations about, what exactly is the ACO value proposition? What can the ACOs do for the managed care organizations that they couldn't do for themselves? And there's certainly a lot of dialogue around this. The ACOs are closer to the patients. They know the patients. They know the other community organizations, social service providers, and things like that. So how do you connect what the ACOs are good at with what the managed care organizations want to do? And how do you put a dollar value on that? That's where a lot of the conversations are right now. In terms of funding, looks like the state funds are probably exhausted. You can always go back and ask for more money, but probably the state funds are exhausted. So the ACOs are really surviving mostly on grant-based funding for now. Early on, there was some hope that we're going to do at least something with shared savings. I think the shared savings idea is kind of on hold, and there's more thinking about more direct service contracts for the kinds of work that ACOs would do, particularly in collaboration with the managed care organizations. So I mentioned earlier that the official demonstration is coming to an end soon. So here are a few next steps for the demo and the evaluation component of that. So we have looked at some quantitative metrics for the 3 ACO communities. We have a quantitative report based on the Medicaid claims and encounter data currently under review with the state. Mostly this is a baseline report looking at activities through year 1 of the demonstration, looking at some broad-based population health kinds of indicators. That's under review, but it should be made public within a couple months, I would suppose. Let's see, we're doing some additional quantitative analysis for years 2 and 3. We're currently building the databases for that and creating the measures. Also, in conversations with the ACOs, we're learning in a little more detail about which population groups they're really focused on. And so our years 2 and 3 analysis will look harder at those particular populations rather than looking across the entire community where they might not be doing anything in particular for quite so many people. We have a year 2 qualitative report that's currently in progress. I highlighted a handful of initial themes, but we'll have more details to report on, and that should be out in a few months as well. And then we're going to do the year 3 qualitative analysis as well, but a lot of the final analysis obviously has to occur after the demonstration is over, once all the activity, at least officially, is done, and then we can look back, gather the data, and reflect on everything that happened. And of course, once the demonstration ends, everybody wonders, well, what comes next? Will there be an ACO 2.0 or some other thing? Currently, the state of New Jersey is considering, all that sort of thing. Nothing official yet, but at some point we'll hear about what comes next in terms of these three Medicaid ACOs in particular, and more broadly, how's New Jersey thinking about Medicaid ACOs as part of the Medicaid program in general. So I'll end really with a handful of takeaways. Essentially, what have we learned so far? So ACOs have made progress in a number of areas. Coalition building has been ongoing. Really, I think a lot of progress has been made with the data analytics, particularly with the Medicaid claims and encounter data, integrating that with other coalition data that's available directly from healthcare providers in the coalition. And the ACOs are developing some targeted interventions for particular population subgroups. Not necessarily citywide, but for particular populations. Ultimately, the ACOs, I think, have operated very creatively, but really cautiously, largely because of the uncertain funding. So moving cautiously there, and of course the limited managed care participation has really impacted the scale and the scope of what the ACOs can really set out to do. But despite some of the setbacks and barriers here and there, I would say there's still really high enthusiasm among the ACO coalitions to continue doing the work that they're doing, even to expand the work that they're doing. The question is really, finding a way to do it, but I think the enthusiasm is there. I don't expect the ACOs to disappear once the demonstration officially ends. The question is, how do they exist, in what form, and if there's going to be a new iteration of accountable care in New Jersey Medicaid, there's a handful of issues that I think rise to the top. The first is the details around certification and, what is the definition of a Medicaid ACO? Potentially, you can revisit that to maybe add more community coalitions or just sharpen what it means to be an ACO. Managed care organization involvement is really key here. Either you mandate participation or have some kind of incentive built in so that you can get more managed care activity. If the managed care organizations really don't want to participate, then that does limit how much the ACOs could achieve without the managed care partnership on the other end. The scale of community-level interventions, that's another issue. I mentioned earlier, we tend to think of ACOs as covering broad geography, broad populations, population health kind of activities that you hope to see in broad claims data. That's worth revisiting. Can the ACOs do this in their current form? Should we set the expectations lower, or should we keep the expectations high but fill in the resources that are needed? Certainly, if you have high expectations, then you need the resources to pull that off. And I think currently that's where we are now with the demonstration. My last slide, I just listed a few reports that have come out around the demonstration so far. One of them is under review, which I mentioned, so you can look for that in a few months. And then after the webinar, if anyone has any questions or would like to contact me, I put my email here.
Thank you, Derek. It looks like we have two questions. One coming from Chad Mulvaney. Were pharma costs incorporated into the total cost of care calculation?
Yes. So for the fee-for-service population, the answer is yes, because the according to the state rules, this is really total cost of care. So it's really everything. It's inpatient, outpatient, pharma, and so on.
Great. And the second question, also coming from Chad Mulvaney, is would you provide examples of some of the innovations under Theme 2 that ACOs are developing/deploying?
Yeah, I could. I can speak really broadly and generally about. Certainly Camden has all the initiatives that are easy to name because they've been doing it for a long time. So certainly, the 7-day pledge is something that is innovative, and it's the work of the coalition. Providers are given financial incentives where if they meet their pledge targets, there's they get checks from the coalition, and it's not big money, but it's enough money to kind of get their attention. And when folks from the coalition show up with a check, they can have a conversation with the primary care provider about what's going on what's going on with your patients, what's working, what's not working, how can we help you do a better job. So that's a particular innovation that Camden is doing. The others, I think, are really developing. I know there's some on the phone. I know they would chime in and tell you in more detail if we had a phone link up. But to answer that, you could always email me and I can check back on the details. Like I said, we're in the process of combing through transcripts from our interviews, so I'll have more details on specific innovations a bit later, but you can always email me and I could provide more detail on that.
Well, great. We'd like to take this opportunity to thank our speaker and all of our participants for joining us today. We will be sending up a follow-up post-event feedback email before the close of business today, and would love to receive feedback for any of that you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.